Resume. Okay, so welcome to our COVID-19 and maternal and infant health town hall event today. My name is Kristen Nyan. I use she, her pronouns. I'm the capacity building director at EverThrive, Illinois. And for those of you, if this is your first town hall event, we launched these town halls in partnership with the Illinois Department of Public Health at the beginning of the pandemic to highlight emerging issues and topics related to COVID-19. And today we'll be hearing from presenters on substance use and prevention for pregnant and recently pregnant people. And we have a great group of speakers with us today who I'm excited to introduce. So for those of you who are not familiar with EverThrive Illinois, or those who are familiar with us, but maybe haven't seen our new mission, vision, and values yet, for more than 30 years, EverThrive Illinois has been advancing the health and safety of Illinoisans by supporting access to quality healthcare and providing resources to achieve health equity. Our aim is to affirm and center the experiences and voices of communities most impacted by injustice to achieve reproductive justice for all people and families, especially those in Black, Brown, Indigenous, and LGBTQIA communities. We ensure that everyone has the access, resources, and healthcare necessary to create and sustain healthy families on their own terms. Some brief housekeeping before we get started. If everyone could make sure you're muted to reduce background noise, and I may mute you if you forget to mute yourself on accident, just so we don't have a lot of background noise. We'll send a follow-up email to everyone who registered today with the recording as well as the presentation slides. And then feel free to type questions into the chat box as we go. We'll hold off and do a round of Q&A towards the end of the presentation, but definitely feel free as questions pop up to include them in the chat. Our brief agenda today. So we'll do introductions, which we're doing now. I have the presentation on substance use and treatment in pregnant and postpartum people by Dr. Deja Finley, Dr. Sophia McNeese-Ruffin, and by Charity Bean. Then we'll have the Q&A period, followed by resource sharing and a brief wrap up. So here's lovely photos of our wonderful presenters who I'll go ahead and introduce. So Dr. Deja Finley graduated with her bachelor's in chemistry from Millikan University in 2015 and obtained her Doctor of Pharmacy degree from SIU Edwardsville School of Pharmacy in 2020. She completed a PGY1 community-based pharmacy residency program in 2021 and joined the faculty at the SIU Alton Family Medicine Residency Program as a clinical pharmacist. In addition to being pharmacy faculty for the SIU Alton Family Medicine Residency Program, Dr. Finley is a clinical assistant professor of pharmacy practice at SIU Edwardsville School of Pharmacy, and she's a native of East St. Louis, Illinois. Then our second presenter, Dr. McNeese-Ruffin, is a board-certified family medicine physician who trained at SIU Center for Family Medicine in Springfield, Illinois, where she specialized in women's health and was chief resident. She graduated with a Bachelor of Arts in Psychology from the University of Illinois at Springfield in 2005 and a Doctorate of Medicine from Southern Illinois University School of Medicine in 2013. Commissioned to the United States Navy in 2008, Dr. McNeese served on the family medicine team in Okinawa, Japan for 3+ years, treating our nation's active duty and dependents stationed in the region. She served 1 year as faculty for family medicine residency at Naval Medical Center Camp Leguin, I hope I said that right, in North Carolina, and assistant professor, Uniformed Services University of Health Sciences until she joined SIU Family Medicine Residency, Alton, Illinois, as associate program director and director of obstetrics and women's health. Most recently, Dr. McNeese-Ruffin has was chosen as a Health Equity Fellow for AAFP, for which she, alongside with Dr. Finley, has formed a quality initiative project, WOMS, which stands for Wrapping Integrating Low-Risk Obstetric Services for Moms and Babies in St. Clair and surrounding counties to help cultivate a new standard of perinatal care. And as a personal aside, Dr. McNeese is particularly identifies with this group of participants as she has served as a foster care specialist and caseworker for Lutheran Social Services as she found her way to medical school. She desires to inspire her community to live healthier lives, and she believes that she personifies perseverance and hopes to be a role model and champion for all women, patients, and future residents that she'll serve. And the last lovely presenters in our star lineup today is Charity Bean, who is a certified pregnancy, labor, childbirth, and postpartum doula. She is a certified medical assistant, certified nurse assistant, and now a student RN with Chamberlain College of Nursing. She has been a unit secretary and patient care tech at Memorial Hospital East in the Family Care Birthing Center for 6 years, as well as worked in the medical field for 13 years. She is also a community activist. She supports and advocates for Black Lives Matter and the Black maternal mortality crisis. When she finishes school with her BSN, she plans to go on and receive her MPH, specializing in maternal and infant health. She has held many community events, including 2 doula community baby showers centered on spreading the word of doulas and how to help create better birth outcomes, and are part of the birth team. Doula Bean Maternal Care, LLC, was created to help educate, advocate, and empower every birth, no matter race, gender, or financial class. They strive to be a community-based small business that is truly a part of and for the community. By providing detailed and custom childbirth and postpartum classes that include the entire support system, they're here to truly explain the ins and outs of childbirth, as well as complications that can arise. Doula Bean wants everyone to know that their birth matters, especially people of color. They're fighting to put an end to fear-based maternal care and the maternal infant mortality rate that is continuing to rise in the Black communities. So welcome, huge warm welcome to all of our amazing presenters. So I'm going to stop sharing and then kick it over to them so that they can start their presentation. Thank you so much, the 3 of you, for joining us today.
Hi, everyone. Can everyone see my screen okay?
Yes, we can.
Good. Okay, so thank you, Kristen, for those introductions. So I know that she already introduced us, but I want to introduce myself again. So my name is DJ Finley, and I'm the pharmacist that's going to be presenting today. So as she mentioned, we started a quality improvement project, Dr. McNeese Ruffin and I, and it is entitled Womb. So wrapping obstetric services for moms and babies in St. Clair and surrounding counties. She already introduced us, but there are our photos again. So again, Dr. McNeese Ruffin is the physician, I'm the pharmacist, and Charity is the doula. All right, so before we get started, I want to go ahead and give you our objectives for this presentation. And I also want to give you the opportunity that just to let you know that throughout this presentation, you can feel free to write comments in the chat. I definitely want it to be an open discussion. This is a way for us to kind of work together as providers and work together kind of as leaders in healthcare to be able to, you know, help women and pregnant women. So just don't feel like you have to wait till the end to ask a question or to create a discussion point. Also, I want to warn you that we will be asking questions throughout the presentation and it's going to require some participation. So get ready for that. All right, so by the end of this presentation, you should be able to explain the goals of the WOMBS project, understand and appreciate the importance of doulas, such as Charity, review legislation surrounding the reformation of the perinatal course, offer resources to moms in St. Clair County and surrounding areas during the perinatal course, and also discover ways that you can be of service to increase the quality of care of maternal and fetal health, especially in African American women. So has anyone heard of Hear Her? Who's heard of that? Can you guys see the chat? I don't think I can see the chat when I'm sharing. Yes, looks like some people are saying they heard. So Amanda, you've heard of it? A couple people say it's the first time of them hearing it. Okay, so Yeah, good. So that means you'll at least learn one thing today, right? So I'm going to tell you what it is. So Hear Her is a national campaign initiated by the CDC that brings attention to pregnancy-related deaths and provides education and encouragement to pregnant and postpartum women, particularly within 1 year of delivery. So I don't have to tell you guys, you're social workers, so you know that there is an additional crisis in addition to COVID, right? So it's the pregnancy mortality going up in the United States, despite us being such a rich country. So I'm going to turn it over to Dr. McNeese Ruffin to talk to you guys about these trends relating to pregnancy mortality in the United States.
Yes, hello everyone. I'm so happy to be here. But as DJ or Dr. Finley already has stated, we have ever rising crisis and trends in pregnancy-related mortality in our moms and infants. And this chart is just to show you how that rise from 1987 to 2015, despite our intervention, we still seem to see a great increase. And just to reiterate that Hear Her campaign, although it is, for every woman to be heard and to listen to her complaints as she is being seen by providers, it is especially targeted to women in underrepresented communities of minority descent and more maternal deserts, which we'll talk about later, which tend to be in the underrepresented communities, but this is particularly a crisis in Southern Illinois, as where we are from. I know that I'll show a map later, but we tend to focus on our urban cities, the biggest one being in Chicago, when we talk about Illinois and maternal fetal medicine. But I just pose to y'all to not forget Southern Illinois in that region down there.
Yeah, sure. So thank you, Dr. McNeese Ruffin. And as she said, there is a severe issue with this rise in mortality, but for Black women in particular, there is a 3 to 4 times increase in rate of death when talking about pregnancy-related deaths. So we're going to watch a brief video here to talk about Hear Her. Yeah, please. Should be playing. Give me just a second. I think maybe it didn't translate right, so I'll just go to the video.
While DJ is pulling up the video, do any of you have any questions in the meantime that you're hoping to get from this lecture, or any questions that we can answer specifically about the Southern Illinois region for you? Oh, we got it.
We got it. But still feel free to ask any questions that you have. And let me know if you can hear it. Give me a thumbs up if you can hear it.
Face was swollen. They're the ones she confided in about her change in vision and headache that wouldn't go away. He's the one who really listened when she said that something just didn't feel right. When she had chest pains a few weeks after delivery, she's the one who insisted on admitting her to the hospital. Too many women die from pregnancy-related complications each year in the U.S. Death can occur during and up to a year after pregnancy. It doesn't have to be that way. Most deaths are preventable. Know the warning signs, hear her concerns. You could help save her life. Learn more at cdc.gov/hearher.
Good. So that video, I know it was kind of just an overview, and it talked a little bit about how different people can contribute to recognizing signs. It doesn't have to just be the doctor. It doesn't have to just be the nurse. It can be anyone that can recognize the signs. And so Dr. McNeese Ruffin is going to talk about some of the signs that can lead us to start talking, or can lead us to just take a stop and a listen to maybe these signs can maybe be leading to something that's a little bit more serious and may require emergency help.
Yeah, and I won't take a whole lot of time to go over each one of these symptoms. And I want to just direct you to the fact that this poster is available on the CDC. So my charge to all of us on this call is to always advocate and educate. And so we're advocating for our moms and our clients that you'll be advocating for them, because you might be the one that they're telling these symptoms to, and not and feeling like they're not being heard by their medical providers, but also to educate them on the signs to look for. I know the video kind of skipped around a little bit, and I'm hoping that we can send you all the link. And there are separate stories, specifically on the Hear Her campaign, that you may be able to share or watch. But, as it will say, it will be, the kids, their children, who will recognize their mom is not right, or, husbands and friends. And a lot of times their symptoms are not taken into considerations with the providers that they're seeing. And, they kind of say, oh, we'll just watch it for a little while. So it's our job to kind of push. I always feel like patients to me are like my family. So it's like, what would I want for my sister? What would I want for my mother? And so as we are dealing with our clients and our patients, we just need to know these signs. And we'll send this poster to you so that you can have a copy.
Okay, so that kind of leads us into talking a little bit about African American patients in general. So there's a new term that we're using called weathering. And basically that talks about these long-term stressors that African American females are experiencing that lend to physical manifestations. So in particular, with this presentation, we're talking about chronic conditions such as maternal and infant mortality, but it can lead to other conditions as well, such as hypertension, obesity, and diabetes, which also lend to poor prognosis with pregnancy and also length of life. So African American women can be described as survivors of perpetual trauma, and they are in need of increased access to providers that are skilled in trauma-informed care. I know, all of us are educated in trauma-informed care, but in particular, the research has shown that, that increases outcomes, or better outcomes, for African American women when they have people in that. And I don't mean that just their providers have to be trauma informed. I mean everyone from the front desk all the way to the housekeeping, all the way to everyone kind of in the system being trauma informed. So these disparities in maternal and fetal health in African American females continue to be at the forefront of clinical awareness, and with increased rates of infant and maternal mortality. So for all of us providing care for them, there remains an urgency to aid in mitigating treatments and management for this unequal balance. So just keep that term in mind. I'm sure you'll be hearing it here a lot.
DJ, I wanted to point out, so I know that term, and one is kind of used in research a lot as it pertains to African American females, but just to give you like practical visuals of this. For a lot of times, in the African American culture, we are seen as strength, and that nothing is really of concern and bothers us. And as African American females, the theory is that we have always been at this baseline stress, and we have always taken on this baseline hardship. And so it is important to, especially the campaign, when we say hear her, is that one, most of us, and I would say a lot of women in general, but it's found, especially in the African American community, that we're not going to the doctor. And when we say we have a headache, it's probably one of the worst headaches we've ever had. So we're not going in with just, I woke up with a headache this morning, and so, could you check it out? And so we need to, a lot of times, as it pertains to maternal and fetal health, they say that we can take pain on, people will say, oh, it seems like African Americans can take more pain. And that's not I don't think that that's the case, but we have, again, been able to weather some of these stressors. And so a lot of times we don't speak up until it's an extreme. And that's the key that you need to pick up on, is that a lot of times when they're coming to see you, they're complaining, they're already at an extreme of those symptoms.
Thank you, Dr. McNeese Ruffin. Okay, so that kind of leads us into another one of the reasons why this is important, or another organization that is supportive of, talking about this African American maternal health. So, not sure if anyone has heard of the Black Maternal Health Momnibus Act. Momnibus is a play on words. It is supposed to be like omnibus, but momnibus. And I know Charity can share a little bit about that. So I'll pass it over to her in a second. And then the other piece of legislation is the Illinois House Bill 158. So I'll talk a little bit about that. But the Black Maternal Health Momnibus Act, I want to just give a brief introduction, and then Charity, you can add something as well. So it was basically created by Congresswoman Lauren Underwood, Alma Adams, and also Senator Cory Booker. They are members of the Black Maternal Health Caucus, and they introduced this in 2021. Now, there are several bills attached to the Black Maternal Health Momnibus Act, but these bills specifically that I listed here kind of go along with the WOMBS project. And so, it talks about basically making investments to social determinants of health and providing funding to community-based organizations, also making sure that we have culturally congruent maternity care. So there's been lots of research showing that, patients are have increased, health or improved health outcomes when they have providers that are able to understand them culturally and that also look like them. And then also supporting moms with health conditions and substance use disorders. So Charity, if you want to add a little bit here.
Okay, sorry, absolutely. So to add to that, so each state has received a significant amount of funding to use with this project. And so, for example, the state of Illinois, we worked diligently last year to get the bill passed and to add things to this, such as doula coverage. So for the state of Illinois, as of July 1st, doulas will be covered by Medicaid, which is going to help with the maternal mortality crisis. They've had studies showing in areas such as Chicago, showing the benefits of doulas who have been around for literally centuries. And so each state—
Charity, we have later on, we'll talk about doulas. So I don't want you to get too ahead of yourself. It's okay. I don't want you to get too ahead of yourself.
Okay, but yeah, that's pretty much the portion of it. Each state has funding, and each state is, from what my understanding, each state is kind of working together with their funding for the Momnibus Act to see what they can do with the funds and what areas they can continue to help to target to help eliminate the Black maternal mortality crisis and maternal crisis as well.
Good, thank you. And then also Illinois House Bill 158, which is also called Illinois Healthcare and Human Service Reform Act. And that is also an act to basically, that's already been passed to help improve health outcomes of Black residents in the state of Illinois. And that was kind of what Charity was talking about with the doulas. And we'll talk about that a little bit later as well. Okay, so that brings me to the goals of our project. So our project, also called Wounds, it is basically to reform the standard perinatal course. And we're going to do that by these 6 things. So extending the course to 3 months postpartum, paying close attention to maternal or to behavioral health and addiction, taking close consideration to social determinants of health, incorporating home visits, incorporating doula services, and then having a retreat for all of the moms that are involved. And throughout the rest of this presentation, we'll talk about kind of the reasons why we're doing, or we are pursuing all of these goals and how we're going to achieve them. So if you guys could go to pollev.com/DJFinley962 or text DJ Finley 962 to the number here, 37607. Going to use this platform to be able to ask questions throughout the presentation. And we can kind of see what the consensus is. So let me know if you guys are getting any answers. Not
I
yet.
was gonna say, I'll paste it in the chat too, so that folks
Okay.
can just
Perfect. Is the first question activated? Okay. So on the poll everywhere, you should see the first question once you log on. What proportion of maternal deaths occur greater than 2 months after pregnancy? Okay. So I'll actually, you might want to see the answers. So it looks like answers are rolling in. We'll give you guys a second. I don't think I'll be able to share. I don't think I'll be able to share.
It looks like a lot of it was between 30 to 40%. Now it's kind of increasing to 45%.
Okay, so it looks like many people are answering what, 30 to 40%. Okay, yeah, 30 to 40%. That's a good estimate. So it's about 1/3 of patients. So about 1/3 of deaths occur greater than 2 months after pregnancy, which is past the 6-week follow-up that's typical for the perinatal course. And so that's why our first goal is to extend that course to 3 months afterwards. And Dr. McNeese Ruffin, do you want to add to that? You're muted.
Sorry. No, DJ, the facts are the facts. You know, we oftentimes, even if we think it's important to see our moms 6 weeks postpartum, that's the standard as of right now. And studies have continued to show that adverse events are happening long after that 6-week visit. And so it's important for us to advocate for more and increased follow-up.
Good. Okay, so have you guys heard of the term maternity desert? We're going to talk about maternity deserts in a second. So feel free to type in the chat. Not at all. Maternity deserts looks like some people have not. Okay, some people have. All right, so you'll learn a couple of things. Dr. McNeese, you want to talk to them about maternity deserts?
Sure. So this is a term, used across the United States and in the studies, and basically definition is here. Counties in which access to maternity care services is limited or absent, either through lack of services or barriers to a woman's ability to access that care. So we know just from, as we work on these services, and we know the barriers that our mothers are having to go through with the closures of hospital wings for labor and delivery, with a decreased number of OBs, or any provider that can deliver FMOBs, midwives, that can deliver babies. And so Lisa wants to go back to the slide description. So, and we can definitely send this PowerPoint to everyone. It's no problem. But I just wanted you all to pay particular attention, and it's really hard to see kind of Illinois in the outline. But as it shows in red, the maternity care deserts, as you can see, red being the extreme of that desert, we are right there, like Madison, St. Clair, right on the river line, and right over into St. Louis, Missouri. That is a desert. Whereas you see, in contrast to Chicago, they almost are at moderate access to maternal care. And so I know that we oftentimes focus on the urban areas, but those who need it the most in our state would be right in these counties that we currently serve right now.
Okay, thank you. So if you guys want to go back to poll everywhere, you'll just keep it up because we'll have a few more questions here. So you'll see the question, how many women in the US live in a maternity desert? How many do you think? Looks like 1.6 is taking the lead, okay.
50%.
Okay, about 50% of people are saying 1.6. All right, so the choices are 750,000, 1.6 million, 5 million, or 2.2 million. So those of you that picked 1.6, pretty close. It's more than 2.2 million. So if that is not a kind of upsetting number, I don't know what is. So 2.2 million people living in maternity deserts. And I'm sure you didn't even think that Southern Illinois was one of them. So it looks like I'm reading in the chat that someone is saying, thanks for that information. I didn't even realize it. And so here we've just included quite a few stats about patients that are living, in these maternity deserts that have like lower household income, which is also going to increase the risk of negative effects during pregnancy. So you'll have access to these slides later and you can look at that, but 2.2 million. All right, so we got another poll everywhere question. What is the #1 cause of pregnancy-related deaths in African-American females? Looks like someone said heart conditions, no prenatal care, cardiac, infection or sepsis. These are some good answers. Cardiac arrest, poor aftercare, hypertension. I wish you guys could see these. Yeah, it looks like prenatal care, hypertension. Good. So not quite. The answer is mental health and addiction. That's the #1 cause. of pregnancy-related deaths. So luckily, and it's followed second by chronic conditions such as hypertension, cardiac reasons, and stuff like that. So that's why we have a clinical pharmacist on board for our patients that are going to participate in this project. So for these patients, we have a prenatal screening and assessment. And the reason why I have informed consent highlighted here is because we want to make sure that our patients are given autonomy when they are coming to us for help, because a lot of patients will not have any help whatsoever during the perinatal course because they might fear the consequences, or if they have substance abuse or a substance use disorder, they might be afraid to come see a provider. So we want to make sure we give them informed consent and let them know kind of what they're getting themselves into whenever they're taking these screenings and stuff. And another thing I wanted to bring awareness to is the term substance use disorder or substance abuse, especially as it pertains to the use of marijuana or cannabis. That is a pretty charged word. And I think we're kind of getting away from using substance use disorder when it comes to someone that's testing positive for marijuana, particularly because it has become legal in quite a few states and it's just pretty charged. So we're gonna stay away from that, just thinking about the trauma-informed care and stuff like that and wanting to be sensitive to our patients. Nevertheless, it can give an opportunity for a positive change for our patients, to give them an opportunity to, hey, this could be the start of something new. I can address the issues, I can address the risk with you, without being judgmental or without, categorizing you in a certain box. Another thing that I'm going to be helping with is managing pharmacotherapy during pregnancy. So that's for patients that have opioid use disorder or that are on any different medication, especially those with mental health. So thinking about the use of antidepressant medicine and medicines that are used for bipolar disorder and other abnormalities, just thinking, weighing the risk versus the benefit of the baby and for the mom. And so I'll be there on board for that. And then also talking to patients about peripartum pain relief and giving them education on that. So, giving them the information to be able to create a informed decision and giving them the self-efficacy to be able to decide instead of waiting until the moment that they're giving birth to have to make those decisions while they're in pain or, while they feel like they're kind of under a lot of pressure. So they'll be provided that information throughout their pregnancy. And the next thing is that we are going to make sure to screen for social determinants of health using the PREPARE method. So that is, I can open up. And I wish I could open it up, but I can't open it up. So it's basically a screening tool for social determinants of health that was created by AAFP. And it basically asks the patient about different demographics, what race they are, what education they have, what needs do they have. And basically that's an area where I think social work can be really helpful, because sometimes we don't even know what is needed. And so we kind of create a baseline of making sure that we screen all of our patients at the beginning, and then we can know what they need to have the best outcomes. Anything to add on that, Dr. McNeese?
No, I think you stated it well. I really want to try to get to questions that people have.
Yeah, we're getting there.
Elaborate much more on that.
Yeah, we're getting there.
Yeah.
Okay. All right. So the next part is, of course, we talked about incorporating doulas into the perinatal course. And so I want you to open up the poll everywhere one more time. And I want you to name some benefits of working with doulas before Charity comes in and tells you all the good stuff. Support, education, advocacy, absolutely. Emotional support, yep. Less stress. Advocate support, knowledge, good. Maternal support, emotional support, advocacy. So yeah, it looks like we have some trends. So that means we have a pretty educated group here. You guys already know the benefits of doulas, but we'll have Charity to elaborate a little bit more on that. If you want to take it away.
All righty. Thank you for having me. And I also like to add that I am also here charity douling, and I'm also a Healthy Start case manager. And so I'm here with the Healthy Start team as well. In my background, they watch me, they got me nervous. But yeah, I'm here as well. And the work that we also do in the community with helping provide education and knowledge and keeping our clients safe and just help promoting better birth outcomes. So I'm going to present a little bit about benefits of having a doula and give you like an example of each one of these things so it makes a little more sense. First thing I want to say though, starting with having a doula is not a luxury, it's a necessity. And unfortunately for Black women, we tend to think that this is something that we shouldn't have or can't afford to have, or, oh, that's a white woman thing. But in actuality, this is your culture. This has always been your culture, and birth has always been our art. And we have to get back to that knowledge and empowering ourselves and our families and knowing that things that come with pregnancy and birth and postpartum, that support, that love, that advocacy, and that education is your birthright. So, but with that being said, we'll get into the details of having a doula. So as we said, physical comfort. So having a doula as far as physical comfort during labor, providing things such as massage, compressions, assistance with trusting your body, following the position changes, what your body is telling you, being that guide to help you through those waves, as I like to call them instead of contractions, through the laboring process and birthing process, as well as guidance and support for the loved ones. So doulas play a huge factor in this by providing evidence-based knowledge for the families based on research, things such as where you tell your mom or whomever, your grandma, hey, I want to have a doula, and what you need that for? People been having babies for forever. So being able to come in and explain the benefits of having that support, are the benefits of not using certain medications and things if that's not something they want to do. Just being that person to help bridge that gap of letting other families understand what can happen during labor, creating safe spaces as well with that family to help advocate and empower that family, such as people coming in and putting their birth trauma into them. For example, if you have a grandma or aunt or someone's like, oh, wait, you think you're gonna go all natural, but once them contractions kick in, woo, you're gonna tap out. Well, that's birth trauma. That is not for you to put into that person. That is for you to, and you're supposed to empower that person and tell them if that's what you wanna do, you can do it. So having a doula there so that your family doesn't defeat you with your birth goals. Also, when we say, also when we say, decrease in length of labor. So by teaching your clients to trust their bodies, this is letting them know that yes, you can be at home in that early stage of labor, laboring at home as long as you can, as long as you're not a person with complications or anything have arisen, for example, like high blood pressure. Being able to be at home and get through that early stage of the laboring process, going to walk, I always tell people, go to Target, go get on that buggy and you just walk that store till you can't walk anymore to help get your body into a labor pattern so you don't also keep getting sent home and then feeling like, oh, nobody cares about me. That can also help decrease the pushing times. Emotional reinsurance and empowerment is empowering every birthing person, just remind them, hey, you can do this. You remember your plan. You said you want to walk this baby down, or just saying, don't give up on yourself. I know it's hard, just reminding them that they can do that. And you would be surprised, as we explained, labor is a marathon, it's not a race. So it does get exhausting and it is hard on the body. So having somebody there pouring into you, telling you, hey, don't forget you can do this. What can I do to comfort you? Also, as we say, breastfeeding assistance. So during the time when you meet your doula, you're establishing a relationship, a bond with that person. So that goes also into emotional support. But now that I have a bond with this person, I'm educating them throughout the process. That's that early on education about breastfeeding. So we don't wait till you actually have the baby to teach you about it. Let's talk about it now. Let's talk about what that's going to look like for your life. Prepping for that, educating the families on breastfeeding benefits, not having someone, don't feed. If we say don't feed my baby, then sticking with that and holding those boundaries. Do not give a 3-month-old green juice, okay? Stop putting rice in 2-month-olds bottles to tell them they can sleep, you know, telling the benefits of breastfeeding. And again, we're going to go with decreasing a negative birth experience. So by providing education and support throughout the pregnancy, the childbirth, and postpartum, again, going into the relationship, you have that trust with that person. So they have the knowledgeable person also present in that space, in that room, to help control the space for that birthing person, because you are focused on trying to have a baby. So at that time where this can be an emotional time, a happy time for you and that family, still having that comfort of having that person there that has your back in the corner with their knowledge to help ensure that you are getting the best care possible, because it can be scary. Also, as we were saying, explaining labor and postpartum, as well as complications that arise. So from the time you meet with your doula, again, education is key. This can help decrease morbidity and mortality, because it also makes it easier for the client to navigate the pregnancy, birth, and postpartum experience and make the best choices for them. We call them birth plans, but as I tell my clients, having a birth plan is my way of getting you started to do your research on pregnancy and childbirth outcomes and postpartum as well. It's a form of empowerment and opening that gate of conversation with your physician. The doulas also decrease pain medication use by encouraging non-pharmacological methods that people don't know about. So what typically happens, you know, with the mind frame of you go to the hospital, you're just going to go and have a baby. If no one's telling you that you can get up, no one's telling you to walk the hall, use this birthing ball, use this peanut ball, squat, trust your body, keep going to the bathroom, you know, emptying your bladder, keep drinking water. These are things that lead to people, as I say, tapping out sooner, you know, because you're not distracted. So having that changes major things, including position changes, hydrotherapy, music. Make your birth fun. I always tell my clients, make a playlist, you know, whatever music you want to do. This is your birthing experience, so let's make it a happy one. When you're in that room, look at it like you just checked into your hotel suite. Have fun with this. Let's make this a positive outcome, even though it's uncomfortable. It's a mindset. Pregnancy and childbirth are mental. It goes hand in hand with your mental health. Facilitating the communication between the patients and the hospital staff. So doulas do not, for clarification, we do not speak for our clients. I empower my clients with knowledge and education and advocacy for them to make the best decisions for themselves based on the informed consent that I've given them. So when things come up, they're able to make these decisions for themselves, as well as clarifying verbiage. So things that people will get caught up on with a physician, and this is not to bash physicians, but if you don't know the verbiage, this is how you can get tricked. So you ask your OB, hey, can I labor in any position I want to? And of course, your OB say you can labor however you want, but here's the catch. Can I birth in any position I want? Because there's a confusion between that verbiage of actual laboring and childbirth. These are two different stages. So making sure that you're asking the right questions. These are things that can truly change the outcome of the birth and your birthing experience, and traumas possibly occurring during this labor and birth experience. Sorry, guys. Sorry. We also decrease the C-section rate. And how do we do that? That's actually by educating our clients throughout the pregnancy on things such as nutrition, exercise, which is not saying you got to go be a bodybuilder, but making sure you're walking every day, you know, getting up and down, use of birthing balls. You can use them at work to sit on to help with pelvic pressure and pains that lead to preterm labor, use of maternity bands so that we can help lift that baby off your pelvis and also keep your back in a good alignment. These are things that are leading to preterm labor, because your body is in pain. It's in flight or fight mode. We're not supposed to be in fight or fight mode constantly. You know, does any of these things totally eliminate the discomfort? No, it does not. But it makes it easier. It makes it more tolerable. Hydration. Many pregnant people don't even know they're supposed to have 80 to 120 ounces of water per day, and that's pure water. Majority of us, especially as African Americans, have been hydrated or dehydrated our entire lives. We grew up drinking Kool-Aid and Hugos and things like that. You weren't drinking water. You have been totally dehydrated your whole life and just surviving. And again, things of this nature that giving that education can help with the clients, having better birth outcomes, decreasing elective inductions, and allowing the body to go into labor on its own with preparation and making plans, 38 weeks, 40 weeks, implementing those plans. Examples like using nipple stimulation during the laboring process so that you can decrease the odds of receiving Pitocin and letting your body make oxytocin. And we decrease postpartum depression as well because you have that doula support, who's somebody there to just listen to you about your experience with your doula and can relate.
Thank you, Charity. I'm sure they're going to have a lot of questions for you at the end. Thank you so much.
You're welcome.
Okay, so Charity also informed us that Medicaid is going to cover, so you might wonder why, is this even covered by insurance? It is covered by insurance. So 12 prenatal visits, 12 labor hours, and then 12 postpartum visits with your doula. Okay, so the baby shower, which is the retreat that we talked about, that one basically is going to be used to create community for local support, provide reliable information outside of the doctor's office. So I know a lot of times patients feel rushed when they're in the doctor's office because they have time constraints. So that's an opportunity for a day-long retreat to get their questions answered and to create kind of a dialogue between the providers and the patients. Also to identify and provide community resources, to create a pampered experience for them during their second trimester, and then also to review the Black Birthing Bill of Rights. And you can review that on your own, but it's something that I think a lot of Black women, a lot of women in general are not familiar with, and it's their rights, as a patient to be able to, advocate for themselves. So what we need from you guys is to help us advocate and educate. So Dr. McNeese, quickly, you want to go through PRAMs? We don't have a lot of time.
Right. I'm not going to particularly talk as much about this, but I just want to let you all know that under the CDC, they do PRAM stands for Pregnancy Risk Assessment Monitoring System. And what they do is monitor different interventions and give an estimate of how this will positively or negatively affect pregnancy and pregnancy related outcomes. And so just going to the next slide, seeing the top 5 that actually have been shown or estimated to truly affect pregnancy outcome. And so one is that they have had postpartum checkups. And I don't know if you all know, but even down in Southern Illinois, there's a big disparity on even patients showing up to their postpartum visits. 2, they began prenatal care in their first trimester, where we know a lot of our moms were getting late in their pregnancy, months in, and so they're not starting their prenatal care. 3, if they've ever breastfed. And so we, especially in our community, need to continue to encourage breastfeeding, because so often they are not getting that encouragement in the hospitals. They are not getting that, they're able to go to WIC and get their formula. And so we need to make sure that we are pushing breastfeeding is the best feeding. And then 2, the use of postpartum contraception. This is, an outcome that has shown a lot of times we are having moms that, after pregnancy are becoming pregnant again, which will cause some adverse effects. They're becoming pregnant too soon. Our body needs a chance to heal. And that's all I'll say about that, as a provider or as a physician. I don't necessarily like the word provider, but as a physician, we need to, we need to advocate. And as social workers, you need to advocate with your moms, just that period of healing. And then the back to sleep. I know most of you heard our babies being on their back to sleep is also. So those are the top 5, but there are many in that report. And, we can also share a link to that.
Good. And then here are sort of a list of resources that we know are needed, but I want to kind of open it up for discussion as well. So thinking about transportation. So, when we see these patients, will they have reliable transportation for them to come and have their actual OB provider to deliver the baby? Also resources for donations, and then inviting your local doctor, doula, or pharmacist to the home visits whenever social work is going to see patients at home, inviting us to come out with you, and then reaching out to provider's office with questions, or physician's office with questions, whenever you know that these patients have questions. So I know that we don't have a lot of time, but I definitely want to have a discussion. So please write in the chat some things that you might want to talk about or questions you might have, or even, if there is something that you want to offer as a resource, please include it in the chat.
I did see a particular question, and I was really trying to copy and paste it in your chat for you, but you asked about where is that information in that mental health and addiction is the top leading cause, and it is. I know that it was also pasted, the maternity morbidity report for Illinois. It is right in that report in the summary section, and if I can decrease my screen, I will try to pull up even what page number it is for you, but it is in the summary that is the leading cause.
Good question. Thank you for providing that question, because I'm sure if you had that question, other people had that same question. So thank you. What other questions? Oh, it says provider is such an inside word. Yeah.
Yeah, that's a whole discussion in itself. So
I just didn't want to offend anyone, so I just said provider. We're all providing.
We'll have another discussion on the side about that one.
Yeah. And feel free to unmute. We can speak.
Yeah, if you unmute, because I'm trying to follow the chat too, you guys.
Yeah. Some women will reject
Maybe we
support due
can,
to the fear if pregnant.
DJ, you can unshare this screen so I can see people.
Oh, yes. For sure. So it says, some women will reject support due to the fear, if pregnant, that they will be placed in further harm. Okay.
What was the statement?
That some pregnant women may feel like they will be placed in further harm by having support through us. So they'll reject support because they fear.
And I was referring, hi, this is Tamla Milan Alexander with Ever Thrive, Illinois. And it's very close to me, this subject matter, but it really plays into the fear and mistrust in the community of what happens when you do try to ask for certain help, and sort of the stigma that's attached to those who seek treatment. And we have to do better about addressing mental wealth instead of saying, something's wrong with you, such, and me and the provider word is not one that's commonly used. We got clinics and doctors,
Yes.
I'm gonna leave that alone for now. But I will, that's the inside word. But I will say this, when we talk about education, I think we really need to focus on having families advocate with their doulas, with people that seem like they're not really inside the system, but to have some community leadership or liaisons to be able to sort of help them transition into areas of help and support that will be meaningful for them. And so it is more than a notion when people say they're fearful of trying to get help during that time. So that was my 3.5 cents.
Absolutely, I totally agree. And, we know that it is a lot to combat and a lot to get our patients to gain their trust. And, as we sit here, we have 3 African-American females who, are willing and able to serve this community. And I think part of that is incorporating faces like us. Many studies have shown that when they see people who look like them, they're more willing to trust. And I'm not ever going to say that I think that, another way, race cannot serve value in these communities. But, I think it is also important for that to be recognized that, our people need to see our people. And so I think, we need to also be cognizant of that. I think as social workers and caseworkers and doulas, they are the front line. As a physician, I can't see this patient as often as I want to, or follow this patient as often as I can, as I would like. And that's why we also do propose us going out. And I know that we kind of mentioned like the baby showers that we will have, probably triannually well, about 3 times a year. I don't know if that's right, but 3 times a year, so that we can catch our moms. The goal is to catch them in their second trimesters and be able to just sit with them and give them information and love on them. This is going to be like a spa. I'm extra, and everybody knows that about me. So this is like a spa, like experience. So I want them to have a good time and know that there's other things outside of just medical care that we're trying to offer. We're trying to offer you support from the community, and know that the community stands ready to serve you, and other moms stand ready to serve you. So
great, thank you. Okay, so I know we're coming to the end, but I maybe want to address one more. Somebody said that they registered for the Uber Health webinar. CJ Pruitt, are you still on? So there's a.
Yes, I am.
Okay, can you tell
Hi,
us
happy Wednesday.
I'm sorry. Can you tell us about the Uber thing? I'm sorry.
So one of the social determinants of health is the transportation barrier to get the moms to their appointments, whether it's to the grocery store, even to WIC stores, and even for follow-up care. That's like mostly the number one barrier. And so they have an initiative that's called Rise for Moms that Uber has partnered with. And then I recently did see that Lyft has partnered with cancer research. I want to say Equal Hope. They have now, these private share ride companies partnering with these clinics because they know the care and the importance of getting them to their appointments. So I know that is happening. I just got that email a few moments ago. So if somebody can text, I think I have Kristen's email. Do I have your email, Kristen? I can just forward it to you to share
that
out
works.
to everyone.
And I'll put it in the chat too, really quick.
Mm-hmm. And then that way people can register to see, to try to get more information about that.
Sure. Thank you so much.
You're welcome.
Kristen, are we allowed to do a few more minutes or is that it?
So I have a couple of wrap-up slides
Okay.
that I was going to do too. I'm thinking maybe all the questions we didn't get to, I can maybe send and connect with you all afterwards, and then we can connect with folks to get them the answers if that works.
Absolutely.
I'm sorry, there was talk in the chat. We just wanted to know, like, where do you get your funding and like, how are you guys? That's what we were asking about.
Oh, yes. So right now we are currently continuing to work on getting funding, but we do have a grant right now through the SIU, Southern Illinois University School of Medicine, their DEI department. But, we continue to apply for funding to keep this going. For the most part, it can be community, a lot of the interventions and resources that we are undertaking or trying to incorporate don't necessarily need funding, just need someone willing to do.
Okay, because someone else was also saying that, with the governor's early childhood initiative that he has going on and prevention initiative and McVie, that could be like additional funding that could help, with you all. So that's where we were going with that.
Thank you. Appreciate that.
Great. Well, thank you all three so much, and thanks everyone for your questions. I'm sorry we didn't get to all of them. I just have a couple of wrap-up slides really quickly if folks have a couple more minutes to stay on, and we'll get the answers to as many questions as we can after this. So I just wanted to, we've been using these town halls to highlight our new perinatal education toolkit that Everettsburg, Illinois created and recreated and relaunched last year called the Healthy Choices, Healthy Futures Toolkit. And it is broken down by perinatal stage and is a great resource. It's like a compilation of everything or a variety of topics folks would need to know in the pre-interconception, prenatal, and postpartum periods. And I can put the link to this in the chat as well. It's just www.healthychoiceshealthyfutures.org. So folks can go to that when they have a minute. And another exciting thing is that we also just launched a survey. And so if you are using the toolkit, we want to know, is the toolkit working for you? Do you find it helpful? And so the evaluation is on the homepage. And if you have a few minutes, it's anonymous, confidential, less than 10 minutes to complete, and you'll be entered into a raffle to win a $50 gift prize as a little incentive too. So we want to hear y'all's feedback on the toolkit so that we can improve it. And then last, next steps. So we'll, like we shared, we'll send out the presentation materials from today out with everyone. We have a quick 30-second survey and our next town hall will be on Monday, June 13th at 1:00 p.m. And it sounds like CJ will get the Uber webinar to me so that I can share it out with everyone else as well. So folks just have another 30 seconds before we finish. I'll just launch the poll. It's 5 questions about just to get some feedback on the webinar today. So if folks, or 6 questions, folks would be willing to participate before we end, that would be wonderful. Thank you everyone for attending. I know folks are starting to hop off.
Thank you so much.
Yeah.
Nice meeting everyone.
Thank you.
I was going to say, it looks like most people have participated now. So thank you again so much to our 3 presenters, and thank you everyone for joining today. We'll talk to you all soon.
Thank you. Bye.
Bye everyone.